The right torque in the right place. Timing of intervention in non-union. So a lot of other people have started off by saying that they don't necessarily think in their mind along the idea of the traditional definitions of non-union. So I agree with that. I've put that out of the way. And as I mentioned to you before, I had this picture in my mind of what was going on. So we spoke about the normal pathway before. And when we're presented in the clinic, I think we're thinking about, is this a delayed union? Is it progressing? Is it going along? Now, that doesn't mean that we shouldn't intervene. Or is it something which is arrested, where you can see that it's stopped, but you believe that if you change something, it's likely to kickstart the procedure again and you may get to union? Or is it completely in a position where it's now programmed to form a joint and you have a pseudoarthrosis? And I think we may intervene on either of those, the delayed or the arrested path. And it's useful to think about why, because you think about delayed unions as things that you'll just wait and see. So for the operatively managed patients, so not things that you treated non-operatively in the first place, usually what you're looking at as the surgeon is, do you think something's gone wrong already? Do you think it's about to go wrong? Or if you wait, it's eventually going to go wrong? And those are the things that are going through your mind when you're working out about the timing that you're going to have with the patient. Now, I've excluded from my discussion on this, in a similar way to Alex, where you've got extensive bone loss or where you've got obvious infection. To me, they're not really the non-union that I'm looking at. I'm looking at the situation where the bones are there, and why the hell won't they unite? Whereas if there's a big gap there, or if it's full of pus, then you know why they won't unite. There's the ones where you think that you should be a reason. So we've spoken about this. We hope there's a bone healing organ. We hope that around that fracture, something is trying to unite, and we believe that that's the basis of it all. Now, each of us draw our understanding and conceptualize how fractures heal from different times. Now, my time was a bit before others here, being a bit older, and so John Kenwright, who was the professor in Oxford when I arrived, he published on movement around fracture sites and how you could stimulate, and the micromotion came up, how you could stimulate callus formation, and it was necessary to do, and these sorts of pictures were there, and Kenwright was everything. If you look at JK's papers, though, and that's an abstract from it, there's a bit there, and I'll pick out the bit which is of relevance. So this is from John Kenwright's paper in 1998. He says that it comes to the conclusion that this study indicates that fracture mechanics should be controlled more rigorously to provide amplitudes of movement in the first 4 to 6 weeks after fracture. The rigidity of fixation should be increased in subsequent weeks until the fracture is healed. So that's, it's a long time ago, that's 25 years ago, that concept was there, that what you should be doing is reducing the strain at the fracture site, reducing the movement there at the point you want consolidation. But that is not what we do. Almost invariably, people have a different picture in their mind. You tell patients to get up and walk more. You tell them to do this more. You destabilize constructs. And it's an odd way around. So this chap, I don't have all of the x-rays. This is pre-digital x-rays. So it must be in about the late 1990s. So this chap, we'd fixed him, bridge plated him, and he had, it wasn't too bad really. And he developed, I've put the screw in there, so it's a bit artificial, but that's what was looking at pre-op. He had a clear non-union, just as was shown earlier on. If you have that clear delayed union, but you think you can stabilize it by the addition of something simple, it may be that that's the right way to approach it. And a simple screw was put in there through the plate that was in already and stabilized it. So that seems quite straightforward, and that was what was presented earlier on. And I've been doing that for a lot of years now with a degree of success. So, what about the timing? You're sitting there thinking, when should I do these things? So, with that case, did I believe that it wasn't going to unite? It might have done eventually. But you have in the back of your mind that if it hasn't united, at some point that plate is going to fail, and you'd rather do something before the plate fails rather than a bigger procedure afterwards. Well, in that case, why don't you do it really early on? Just get on with it. And so you can start to think about fracture healing, and this is This is a game that you can play yourself, going back to talking to primary school children. So this is fracture healing in its simplest form. So you have a broken bone, in this case, a pencil at the top there. And I've broken my pencil, recognized I have a broken pencil, and I'm going to make a fracture healing organ. So you get your glue, you get a periosteum, and some tape to stick it on. Basically, you make a fracture healing organ. That takes you time. It takes you time to realize it's broken, go to the shop and buy the stuff. And this is the time that's talking about earlier on. That process at the beginning where the fracture is recognized and the body is recruiting the mechanism to heal it. You can't do that just like that. It takes a finite amount of time. And you put it all together, you've made that, and then you sit there and you watch it and it heals. And that is a pencil healing. It's got one of those in it. I've made a bone healing organ. If you do things to that pencil, if you bend it a lot, you can make it fail. And it's interesting to try it. If you do it, and as that consolidates, as the epoxy consolidates, it becomes more difficult to bend, more difficult to bend, more difficult to bend. But if you keep applying movement to it, eventually it fails. And once it's got a stress riser in it, once it's got a stress concentrator in it, it obviously always fails in the same place and it stays there. So during that process, there is a time at which you get the non-union and you know it's going to be there. From the outside, we don't know it's going to be there, but you can feel it. This isn't biology, though. This is a bit of epoxy, and you can change the process in biology because it still has the propensity to look after itself given the right mechanical environment, so it's not a once and for all. So why not intervene really early? If you can put these screws in, why not put them in straight away? And it's worth looking at the way in which you might picture a fracture. So at the far end, I've got a nice oblique fracture. And you could lag that, that's a piece of cake. And you tend to look at that second, the first of the circular ones, and imagine that that's what you're lagging across. But if you are putting a lag screw into that, what you're doing is very difficult, actually, to get really good compression across there and to get really stable position. You have to be very precise, and you've not got near, I'll show you with the next slide. If you then go to the end picture, where you've left it for some time, it started to develop a plane of non-union, and you've got effectively an extra cortex. So you've got the one on the outside, and you've got along the fracture plane as well. And if you think about that, the working lengths of the screws that you've got in there and what they're trying to do is quite different. The middle one, to compress and to store energy in there, you've got a long working length shown in yellow up there. You've got a small grip on the cortex on either side, and you're requiring to have an accurate reduction of the cortices before you can store any energy in there. Once you've got to the point where it's beginning to change into a pattern with a layer of bone across the non-union site, you've got 4 points of fixation on the screw instead of 2, and the working length is tiny. And I don't think you need to lag those. I don't think there's any point. All you need is very secure hold of the screws, and you get more hold of that if you have all threaded. And so once you get to the point where you imagine that it looks like that far right picture, the screw is a much better hold. And moreover, when you drill, you'll find that it's quite hard to get through the bone. It becomes quite difficult. So, a stitching time saves 9 is what it's a phrase that your mother teaches you, that if you intervene at the right time, you may save yourself a lot of trouble. So that's what I did with this. Intervened at a stage which was early enough before the plate failed, and it worked. Now that was the first one I did. And charged with the idea that this might work in other circumstances, you think, well, where can you extend it to? So this is a young... I've been interrupted by various things. Is this a real one now? We were presenting at an OTS meeting, and there was a solar eclipse. Were you at that meeting? And everyone got...
VLRS Birmingham.
There was an OTS in Coventry. It must have been the same.
I had to drive between.
Yeah, and every bugger got up and walked out to go and watch the solar eclipse, which is very disappointing. Anyway, can the lights go down a bit again? Do we have control over that? So just looking at, can you stabilise under other circumstances? And so this young lady, she'd had a nail in, been in for several months. It had been dynamised, which somebody will talk about again later on, which is a waste of time with nails, I think. And because what you're trying to do is stabilise at the fracture site. And you want the fracture site stabilised. And so put in screws percutaneously, and they're not perpendicular to the fracture site. You can't do that with a transverse fracture, but you can get them in there, and that's about 6 weeks later. And so you can get the right circumstances where you can do something that's very simple. And as for timing, another thing to consider is that with this is done as a day case. You can say to somebody, we're looking at this, we can fix this as a day case with some simple intervention. For me, in my environment, if I wanted to do an exchanged nail, there would be several weeks wait. And so you can say, well, we'll put you on a waiting list to have that done. And so if the simple intervention doesn't work, then we can do a more complex one. And by and large, you don't have to do very many secondary procedures. And so the timing becomes of relevance to the patient because you're more inclined to do a simple intervention early than a complex one, but you want to avoid the complex one later. Is there a time limit at the other end when you can do it? So this chap, he had a significant open fracture. He was nailed. You can see he's got a bit of a malunion. And he did not want another operation. We knew it hadn't united, and he didn't want another operation. He came back 5 years later with that picture that's on the right-hand side, and at that point he was equivocal, but he didn't consent to having the nail done or anything of that the nail exchanged. So again, just stabilise that. And at 5 years, he healed again within quite a short space of time afterwards. So the propensity for healing is there. So that's why, in my mind, that fits with the idea of an arrested union. So it was trying to unite, but there was just something stopping him. If you can break that wall down and he can go through it, then the biology will proceed very nicely. And it worked quite quickly. A stitch in time saves 9. We saw the picture that was shown with the fibula graft before. This chap, he was a professional motorcyclist, and he'd lost a bit of his femur. He'd had fibula graft doubled up and put in there, and you can see he's not uniting as well as you might like, and that was the position that he was in. And you look at that and you think, I do not want that plate to break. If that plate breaks, that is a significant procedure to do something about that. But that's a day case, bring them in, aim the screws very carefully, and it united satisfactorily. So I'm simple. I'm not dealing with the big bone losses that the others are dealing with, but I would very much like my patients not to get to that position where they need that. So try and keep things straightforward. So for the operatively managed patient, when you're going to do it, when you can see something's already gone wrong and you're going to deal with it, as I showed you in that the first presentation, the man who'd broken around his femoral plate, that's obvious you're going to deal with that then. When you think that something is about to go wrong, so when you're looking at plates and you think, oh, I don't know, that's not going to last that much longer, and a plate, how long are you prepared to leave a plate for without the fracture being healed? Depends where it is, but you'll all have a number in your mind where you start to get worried. A nail is probably a bit longer you're prepared to leave that, but again, at some point you'll get worried. And then eventually, some where you look at it and think this is never going to heal, and it's a negotiation with the patient as to when you deal with it. So that's that picture I have in my mind. For non-operatively managed fractures, the question is you have to approach in a slightly different way. And so same things, but it's a clavicle or a humerus. So that's where the argument comes up in this country at the moment, is the advocates for treating clavicular fractures early are by and large, for earlier function, but for preventing non-unions. And similarly, for the humeral shaft fractures as well. And how many do you have to treat to avoid a non-union? And it's going to be whether over a period of time we can make ourselves smart enough to realize which of the patients are going to go onto a non-union. So your number to treat drops to an effective level. At the moment, at the outset with clavicles, you'd be doing about 9 to 1, which is too many people being treated for no particular benefit or for the benefit of one person. But if you can identify at some point the ones that are not going to unite. So in Bristol at the moment, they're looking, they make that judgment quite early at about 3 weeks. And if you've got pain and excessive movement then they'll suggest fixing. To try and screen your population to bring it down to an acceptable level for fixation. So for the non-operatively managed patients, it's a different problem, but and different to conceptualize, and one which comes down to the statistics of it, unless somebody can give us a smart way of identifying the patients who aren't progressing in a sort of non-invasive way. Just a couple of references. So what Alex spoke about, the unified bone theory, the idea of putting the percutaneous screws in, it was an in my hands paper first of all, so we wrote it up first of all, but now it's an in our hands paper, and there's multiple authors on the others. It's a technique that's transferable and worth using. Thanks very much.